Hello, my name is Dr. Hannah. Today we're talking about cardiac murmurs. So we'll be covering the clinical significance of valvular disease, the varying etiologies, the presentations, investigations, and the management of the valve disease. So this slide is just showing some clinical significance of valve disease. So in the top left, you can see strep pneumoniae, and that typically causes endocarditis. The next photo is showing a bicuspid aortic valve. The third photo is showing Marfan syndrome, which is associated with aortic regurg. The bottom right photo is showing erythema marginatum, which is rheumatic fever. And the bottom left photo is IVDU, so intravenous drug use, and typically this is associated with tricuspid regurg. So this diagram is just indicating the different places where we auscultate the heart. Feel free to pause it here and have a quick read about what we're going to be listening to at each area. So the first valve pathology we'll be covering today is the aortic stenosis. So it's the most common valve lesion in the UK, and it has a varying etiology. So typically congenital, so a bicuspid valve, which we saw in that first slide. This typically presents before 65 years of age. We also see senile calcification, and senile, obviously we're expecting this to be in elderly populations, so above 65-year-olds typically. Other, perhaps less common etiologies would be rheumatic fever, subvalvular abnormalities such as HOCM, and supravalvular problems such as Williams syndrome. So in terms of the presentation, typical symptoms might be angina, and we know that the coronary arteries branch off the aorta distal to the aortic valve, so any narrowing of the aortic valve could potentially limit blood flow to the coronary arteries, hence the angina. Syncope, and that's because, again, reduced cardiac output because of the stenosis, reduced cerebral perfusion and syncope, shortness of breath for similar reasons, but also we can get some heart failure and strain of the left heart, so PND, orthopnea and peripheral edema. In terms of the signs, so we might see a narrow pulse pressure, and this is when the systolic and diastolic pressures are closer together than normal. We might see a slow rising pulse, so when we palpate the pulse, we might feel that sort of slow rise of the pulse. On auscultation, we might hear some thrills over the aortic area, and we might hear an end-systolic murmur, which radiates up to the carotids. So in terms of our investigations, on ECG, there are a number of things we might see. Typically, we're looking for a left ventricular hypertrophy and left ventricle strain, and that's because obviously the left ventricle is having to push and work against a narrowed aortic valve. We might also see some left bundle branch block. On echo, again, we might see some evidence of left ventricular hypertrophy, and we might also see a left ventricular septal defect. So as with any medical problem, we always consider the conservative management first of all. If they're asymptomatic and the stenosis is not too severe, then typically we will just advise the patient to avoid exertion, and we'll perform serial echoes to ensure there's no worsening of the stenosis and no ventricular strain that we need to worry about. If they are symptomatic, then really the only management we can do is surgical, so typically a valve replacement, but we can also use a balloon aortic valvuloplasty. So going on to aortic regurg now, acute etiologies would be infective endocarditis, aortic root abnormalities, any traumas or dissection of the proximal aorta, and any failed prosthetic valve. In terms of our chronic etiology, we can still get congenital bicuspid abnormalities leading to regurg, rheumatic heart disease, our soft tissue or connective tissue disorders such as Marfan's and Ehlers-Danlos, ankylosing spondylitis, rheumatoid arthritis and SLE, and infections or inflammatory conditions such as syphilis and Takayasu's. So in terms of our signs, peripheral examination, you might see a capillary pulsation in the nail bed, a collapsing pulse, so you palpate the pulse and lift the arm above the head and feel for the collapsing pulse. On examination of the chest, on palpation you might feel a hyperdynamic apex beat, and on auscultation you might hear an early diastolic murmur in the lower left sternal edge. Investigations, as with stenosis, you might see some left ventricular strain, And on echocardiogram, you might see a dilated left ventricle because of this turbulent blood flow or backflow of blood into the left ventricle. And you might also see some regurgitation jet flow. So on an echocardiogram, you can visualize the direction of the blood flow. And so you might actually see the regurg in that way. In terms of the management, it's similar to aortic stenosis. So if they're asymptomatic and not severe, then we can try conservative management with serial echoes. We can also try to decrease the afterload with ACE inhibitors, calcium channel blockers, or nitrates. If they are symptomatic, it's similar to stenosis again, so valve replacement essentially is the only definitive treatment. So going on to mitral valve now. So stenosis, the etiology, rheumatic heart disease, congenital abnormalities, and atrial myxoma are your three most common causes. In terms of the symptoms, exertional shortness of breath, orthopnea, fatigue, and hemoptysis. And this hemoptysis is due to alveolar capillary rupture. And signs, so you hear about this typical malar flush. AF is another common sign, a tapping apex beat on palpation, and a mid-diastolic murmur. So in terms of our investigations, we're going to start with an ECG, and we might see some AF on the ECG. On echo, we will be able to see the stenosis and tell how severe it is. In terms of our management, if they do have AF, then we'll anticoagulate, rate and rhythm control as we would with any other AF. We can also improve symptoms with diuretics. For any symptomatic patients or any patients with a severe mitral stenosis, again, it's a balloon valvotomy or a mitral valve replacement is your definitive treatment. So mitral regurg now. So really we can categorise mitral regurg into two categories. So a primary valve problem or a secondary problem, i.e. it's more systemic or a problem beyond the valve. So on the primary side, we can have degenerative disease of the mitral valve, infective endocarditis or rheumatic heart disease. Our secondary causes would be ischemic heart disease, MIs or cardiomyopathy. So in terms of symptoms and signs, so typically with mitral regurg, patients are asymptomatic for a long time. They may develop shortness of breath on exertion and other symptoms of heart failure, and there may be some AF as well. In terms of signs, they can have a displaced hyperdynamic apex beat, signs of heart failure as we mentioned, and a blowing pansystolic murmur, loudest at the apex but also radiating round to the axilla. So in terms of investigations, again we're going to do an ECG, and we might see some more signs of left ventricular hypertrophy. So we might see AF, right axis deviation, and left ventricular hypertrophy. On a chest x-ray, we might see some pulmonary congestion and cardiomegaly, particularly in the later stages. And on an echo, we might see a dilated left ventricle because of this regurgitant flow, and we might actually see the jet flow itself on echocardiogram. In terms of management, if they're asymptomatic, we typically monitor with echoes, and if they're symptomatic, we need to replace that valve. So tricuspid now, starting with stenosis. Its etiology is typically rheumatic heart disease, carcinoid disease, or fibroelastosis. On examination, we might see prominent A waves in the JVP, a mid-diastolic murmur, and an opening snap sound. In terms of management, we can give diuretics for reduction of the preload, but ultimately surgery is how we're going to alleviate the patient's symptoms. Tricuspid regurg, the etiology can be because of right ventricular dilatation after failure or pulmonary hypertension, infective endocarditis, in particular intravenous drug users, rheumatic heart disease, and also congenital such as Epstein's anomaly, and this is where the tricuspid valve develops lower down in the heart. In terms of signs, systolic murmur on the left lower sternal edge, and management, again diuretics to reduce the preload, but ultimately surgery. Okay, so this is just a nice little diagram to summarise the findings of the different valve abnormalities. So if they've got normal pulse character, normal pulse pressure and an undisplaced apex, then this is most likely normal or mitral stenosis. If they have a large volume pulse character and a wide pulse pressure, this is typically aortic regurg and we can expect a displaced apex beat. If the pulse character is small volume and the pulse pressure is narrowed, then this is most likely aortic stenosis, and typically the apex position is unaffected. If they have a normal pulse character and a normal pulse pressure but a displaced apex position, this is typically mitral regurg. And finally, this table is summarising the pathologies, symptoms and signs of the different cardiac murmurs. Feel free to pause this and look at in more detail. This concludes our talk on cardiac murmurs, and we'll be talking through some cases in your tutorials. Thank you.